like to welcome all of you. We thought that was really important to have some time to let you know what's going on here at UMMCH regarding substance abuse and a little bit about neonatal abstinence. My name is Cindy Osborne, for those of you that don't know me, and I'm the nurse manager for postpartum. And Becky Gams, who's the advanced practice nurse in the birthplace, she is the co-lead with myself on our SUD-NAS work group. So welcome. Glad you're here. So we're going to start off our first of our three presentations with Rebecca Foell, and I'll tell you a little bit about Rebecca. She's a licensed independent clinical social worker in the state of Minnesota. She obtained her undergraduate degree in sociology at the University of Kansas in 1997. Rebecca went on to pursue her master's degree in social work from the University of Wisconsin-Madison, graduating in 1999. She has dedicated her social work career to working with children and families who have experienced trauma. Rebecca initially provided outpatient clinical services to families and then spent 8 years working in the Dane County District Attorney's Office as a domestic violence child abuse specialist. Rebecca and her family relocated to Minneapolis in 2012. She worked at Children's Minnesota and Health Partners, providing direct service and working on program development. Rebecca started working at the University of Minnesota Masonic Children's Hospital in June of 2015 as a maternal child health social worker. In April of 2016, she became the program coordinator for the Otto Bremer Trust Center for Safe and Healthy Children. As the program coordinator, Rebecca works with the multidisciplinary team to address issues related to child abuse and neglect through direct service, research, prevention, and education. You guys, she has some great things, so I hope you get it all out of her, because it's amazing work what these three women do. But Rebecca has some really good tools for you, and I recommend you listen, ask questions, and have some takeaways. So welcome, Rebecca.
Thank you. Looks like lots of people are coming in, which is great. So that was a wonderful introduction. Thank you. I'm excited to be here today to talk to you guys a little bit about substance use during pregnancy within the context of mandatory reporting. Mandatory reporting is always one of those things that can be really tricky, and people don't really like it. They don't like that they have to do it, but they know that it's an obligation. And so hopefully at the end of this hour, you'll feel like you have a few more tools in your tool belt, just in terms of how to talk to families about this. When do I need to make a report? And those kinds of things. I'm going to go through some of the policy and then talk specifically about state statutes in the state of Minnesota. But I would be happy to answer questions as we move along. So it's fine if you want to interrupt me with questions. Don't feel like you need to wait until the end. I just put in a few slides to give a little bit of information about the Otto Bremer Trust Center for Safe and Healthy Children. I don't know how familiar you guys are with our program, but we've really been growing and growing over the last couple of years. And this is a list of our program team. So Dr. Nancy Harper is our medical director. I'm the program coordinator, and you can see the rest of our staff right there. We actually have our first fellow starting today, so that's super exciting as well. And then here's just a picture of our team that I had to include because it shows that we have a wonderful therapy dog that gets to spend the days with us and also goes up to clinic with us and is actually a really good source of support for the kiddos that we see up in clinic. Real brief, we consider ourselves to be a care model, a center of excellence. We focus on clinical excellence, but we also work on advocacy, research, and education. We have a ton of education opportunities that have to do with child abuse and neglect, and if you're interested in getting on our mailing list, just let us know. And then referral sources, primarily emergency department, inpatient, and trauma services. And then you can see child protection and law enforcement also do a lot of the referring to our agency. And then the type of evaluations we do pretty much are anything having to do with child abuse and neglect. So whether it's, drug exposure like we're talking about here today, but also sexual abuse, physical abuse, neglect, including medical neglect, medical child abuse, fatalities, you kind of name it, and we do it. I'm not going to go into this too much. I just want you guys to know that obviously this child abuse issue is a really big issue, and there's a reason that our center is here, and we want you to know that we are a source of support for you. So these are the stats for 2016. 676,000 victims of child maltreatment, 1,750 kiddos died from abuse and neglect. So pretty big numbers that can be pretty hard to see. But this is what we're here to talk about today. And like I said, ask questions as we move along. So we're going to talk about prenatal drug alcohol exposure. So this is unborn children who are alleged to be prenatally exposed to controlled substances that were not prescribed to mom, or alcohol use which is habitual or excessive. I'm going to go through some of the policy. This policy was recently kind of had a little bit of a overview or made some changes and stuff to it. So I just want to make sure that everybody's really clear about it. So the most important thing right now, I think, is to remember that research really indicates that moms who receive treatment and support during their pregnancy have a better prognosis for their recovery from addiction than if they don't receive that support. And you're going to see improved neonate outcomes with that as well. So what I'm going to talk about a lot today is the importance of the honest communication with mom during her pregnancy and even postpartum, and the importance of the provider having that open dialogue with parents and with mom specifically is really, really important. So mandated reporters shall report all cases of suspected prenatal exposure to controlled substances used for non-medical purposes to the local welfare agency as required by state statute. Has anybody in here made a report to child protection before? Very few hands. Have you ever worked with a social worker who was making a child? Okay, so you've kind of worked with them on it? Okay. And we're really lucky here at Masonic Children's because we have wonderful support from social work. I'm a social worker by background, and I used to work in the maternal child service line. And we really do offer that as a service to support you. But it's also really important for everybody just to know kind of the ins and outs of making a report as well. So a report will be made if the person knows or has reason to believe that a woman is pregnant and has used a controlled substance for a non-medical purpose during pregnancy, including but not limited to THC, or has consumed alcoholic beverages during the pregnancy in any way that is habitual or excessive. So this is what the policy states, and this matches with Minnesota state statute for when a report needs to occur. A toxicology test must be ordered for pregnant women upon admission and any time up to and including 8 hours after delivery if a pregnant patient has OB complications that indicate possible use during pregnancy of a controlled substance for a non-medical purpose. And I'm going to talk to you now a little bit about this exemption to the reporting. Is everybody familiar with the fact that there is this exemption, or is this kind of new? So basically what this states is that a healthcare professional or a social service professional who is mandated to report is exempt from reporting a woman's use or consumption of THC and alcoholic beverages. So we're just talking about THC and alcohol in this exemption, not other drugs. During pregnancy, if the professional is providing the woman with prenatal care or other healthcare services. However, a voluntary report may be made. So any ideas about why this might have been made an exemption? Any thoughts about that? So obviously what we want to happen more than anything is for a mom to receive prenatal care, right? That's the most important thing. We want to make sure that her health is being taken care of and that baby's health is being taken care of. And so this exemption was made because we didn't, state statute and people who were writing the statutes and laws didn't want moms to stop getting the prenatal care that they need. And so if they decided that if somebody was providing that prenatal care, then they're exempt from reporting THC use and alcohol consumption during pregnancy. What I really want to talk about today is that even though there is that exemption, a voluntary report may be made if you have serious concerns about the health and welfare of your patient and the baby. And also to just get you to think a little bit about what that exemption means for the services that you provide. So what does this mean? Even though I'm exempt, should I still report? People often come to me, we get a lot of calls about mandatory reporting, and people often come to me and say, I'm calling to find out if this is reportable. And my response is always, everything is technically reportable. Like, you can report anything to Child Protection if you, in good faith, have concern about child abuse and neglect. The question is whether or not Child Protection will do something with that report, and we can't really answer that question for you. That's going to be something that's going to be determined by Child Protection. A few years ago, Child Protection had a big overhaul, so it was about 2015 when the governor started a task force to work on some of the issues with Child Protection. And one of the things that came out of that is that they can now look at the history behind each report that they get. So if they get a report for child maltreatment and they don't know if they're going to screen it in or not, they can make that decision based on that family's history of child protection reports. So they can go back and say, oh, over the last 5 years, they've received 10 reports similar to this, and that can sort of influence whether or not they open up a case. So a little bit of a tangent, but I always want people to know that whether or not something is reportable, you can always make that report if that feels like the right thing for you to do. It's not our job to investigate, it's our job to make the report and let Child Protection do the investigation. So what are the advantages and disadvantages to reporting? We're going to talk about this a little bit. And then if I don't report, should I still be having a conversation with the family? I'm going to talk about this in just a minute, but as a maternal child health social worker, what I can tell you is that there were lots of times that mom used THC during pregnancy, a report was not made due to the exemption, but nobody ever talked to the mom about A, the risk of using during pregnancy, or B, the fact that a report was going to be made at the time of delivery if she or baby tested positive. Because even though that exemption exists prenatally, it doesn't exist once baby is born. If she or baby tests positive, as a mandated reporter, I have to make that report to Child Protection. So we'll talk a little bit about that as well. And then just this sort of question, who is my patient, mom, baby, both, and how do I treat this system? Just kind of what I just said. So in the intrapartum or postpartum period, Minnesota law requires reporting of suspected or known use of a controlled substance for non-medical purposes and positive drug screens to CPS. So for this, maternal verbal consent must be obtained, and mom can refuse testing for herself. However, she may not refuse testing for her newborn. Toxicology testing of a newborn is required if there is reason to believe, based on the assessment of mom or newborn, that a controlled substance was used by the mom for a non-medical purpose during pregnancy, or when one or more indicator is present. And all of those indicators are in the policy that you can look at. So also in the policy, it states that all women should be informed about planned medical testing, that we should explain and document the reasons for testing, and that we should provide mom with the support in a non-judgmental and compassionate environment. We'll talk a little bit, so I'm going to give you guys some scripting information as well about how we can talk to moms about this. This is not an easy conversation to have, and I know whenever I give these presentations, especially to medical providers, I want to say that I know that this isn't something that you guys are trained to do, nor is it something any of you are probably comfortable doing, but unfortunately, it's sort of the reality of where we are today, and these conversations are really important. We know that patients really look to their medical provider to give them this kind of information, and in the absence of that information, they don't have the knowledge that they need to make a really good informed decision. So this is just more from the policy. If the toxicology test is positive, the nurse will notify the care team if it's moms. If it's newborns, notify the infant's primary provider, social worker, delivering provider, and mom's nurse. And then in the policy, it states that the provider will discuss the results with the pregnant woman or birth mom and provide counseling resources as appropriate. Only one mandated reporter needs to make the report to Child Protection, and that is a very true global statement. It sometimes can get a little bit tricky if, for example, one person feels that there needs to be a report made and one person may not, or if the communication isn't really intact and people don't know if anybody is actually making a report. So like I said here, it's really nice and easy, so I don't want to complicate things. You guys have social workers and you can rely on them to help support with that mandated reporting. But one of my future slides is going to state that mandated reporting is really everyone's responsibility. So if there is a report that needs to be made and you're not confident that it has been made, legally, you're a mandated reporter and need to make sure that that report is made, whether that's double checking with the social worker or making another report. Child protection certainly doesn't want to get 5 reports on the same baby or the same family, but then again, they would certainly rather get more reports than none. So a little bit about documentation. I know that it can be kind of scary to think about putting some of these things in the chart. We want to be really careful what we put in there, and I certainly agree with that. But it's also really important that we document the conversations that we're having with moms about their substance use during pregnancy. And as you guys know, moms are being served prenatally, and then while they're in the hospital, and then once they have their baby, postpartum. And so it's really important that future providers are able to look back and see what kind of conversations took place with moms. I can speak from the role of a social worker, an inpatient social worker. It's really nice to go back and be able to say, this conversation took place between provider or clinic social worker and mom during the pregnancy, because it gives me sort of something to work off of with that patient and to sort of better understand where they're going. The other thing is that people often see child protection reports as being very punitive. And while I recognize that and appreciate it, I also, as a social worker, want to come from a place of advocacy. So I want to make sure that these moms know that a child protection report doesn't necessarily have to mean punitive. It can also mean, as your care team, we are trying to figure out ways to get you the help that you need so that you can maintain your sobriety during pregnancy, hopefully keep child protection out of your life once you have your baby, and make sure that you have a healthy baby as well. So we encourage people to make a note in the chart if they do make a report to child protection, and social workers are typically doing that. I know that there's some concern about families being able to access the chart and then being able to see that, this specific person made the report. I really encourage people to still put a note in there, but I'm happy to talk about that if that's a concern to people. We encourage that documentation to be really clear and concise. It can just simply state that a report was made to child protection due to concern for substance use during pregnancy or due to positive toxicology screen. It doesn't have to be a lengthy note. And then if you're going to be doing ongoing testing, we also encourage a note that a note is placed in there. So ongoing drug testing will occur due to a patient's positive toxicology test. I would add in there discussed with patient or something like that, so that those giving services on the other side are able to see what kind of work's been done and what conversations have been had with the patient. So document that the patient has been made aware of the impact of use on pregnancy, the recommendation to abstain, that CPS will be notified at delivery if mom or baby are positive, and need for ongoing drug testing. So what's really important is for moms to know that, like I said before, even though you might be exempt from needing to report, if she or baby tests positive at the time of delivery, a report is going to be made by a social worker inpatient to child protection. When I was working in the maternal child health service line, I can't even tell you how many times I would go to a patient's room, a mom's room, and I would talk to her about the fact that I had to make a report, which is not an easy conversation to have. And she would say, but my doctor knew I was smoking pot during my pregnancy. I told them, or I told them I was smoking weed. I told them that I was nauseous, and that was the only thing that helped, whatever she might say. And what's really hard is to then explain to them that even though it's an exemption, the conversation really should have been had that if your baby is positive at the time of delivery, that report is going to be made. And I think that that can have an impact. I know a lot of times providers are worried about fracturing the provider-patient relationship, but I would just also encourage you to see that sometimes that relationship can be impacted at the tail end when they kind of are like, why didn't I know about this before? And for the most part, moms and pregnant women really, they don't want to harm their babies, right? So it's having those really difficult conversations, knowing that you're opening the door in a non-judgmental, compassionate way so that they feel comfortable talking with you about their use. Any questions about all that before we move on? Yes? So, yes, the whole marijuana being legal thing has brought in some different issues. But here, so when we're talking about it here in Minnesota, they have to have like a prescription, right? So I have had times where we've gotten a prescription for the use of marijuana and we have not made a report to Child Protection. If they move here and say, well, I was using and it was legal there, you know, I think sometimes it's really hard, and I don't know if anybody else has answers to this, please chime in. I don't know, sometimes it's hard to know, do we trust that? What kind of information do we have to sort of prove that they came from that state? So I would, if it were me, I would still err on the side of having that conversation and most likely making the report on the postpartum end. I don't know if you guys think anything different. It's a tough one. And I think we're seeing it more and more now with even Minnesota stuff. Anything else? Okay. I won't go into this in great detail, but are you guys familiar with ACOG's recommendation? Is that something that you guys are familiar with? If you're not, I would encourage you to look at it. I mean, I'll just go through quickly and say, all women should be asked about their use of tobacco, alcohol, and other drug use, including marijuana that's used for non-medical purposes, that women should be counseled about the use of marijuana and the potential consequences of continued use during their pregnancy, that they should be encouraged to discontinue. I mean, I think sometimes we forget these things. Like, we should even just be saying that it's our recommendation that you don't use marijuana while you're pregnant. Because once we hear about the use, we want nothing to do with it, right? Like, we kind of want away. We want to look away. We don't like conflict, and I understand all of that, but we're really needing to have these conversations. And then be encouraged to discontinue use if they're thinking about getting pregnant, and that there is insufficient data to evaluate the effects of marijuana use on infants during lactation and breastfeeding, and in the absence of such data, marijuana use is discouraged. So they take it to the postpartum as well. So mandatory reporting, this is just, I'm not going to read this. This is the Minnesota state statute on mandatory reporting. And just kind of something that's really good to be familiar with, so you know when you need to make a child maltreatment report. So everybody in this room is going to be a mandated reporter. So it's defined as a professional or professionals delegate who is engaged in the practice of the healing arts, hospital administration, psychological or psychiatric treatment, childcare, education, social services, correctional supervision, probation and correctional services, or law enforcement, or employed as a member of the clergy and received the information while engaged in duties. So that is sort of the all-encompassing definition of who a mandated reporter is. We touched on this a little bit a few minutes ago, so who makes the report? So essentially, if you suspect that a child is being abused or neglected, you cannot shift responsibility to somebody else to make the report. And while we're really lucky here to have social workers who make those reports, if you find yourself in a different situation, maybe a setting where a social worker isn't available, or, you know, isn't there at certain times of the day, then you are required to make a report to Child Protection. So I already asked if anybody has made a report, and we're going to go through a little bit about how to do that, just so you know. Does anybody know the timeline for making a report? So once you suspect child abuse and neglect, how long you have to make a report? Nope. Okay, so I'll just kind of read this first part. So the law requires mandated reporters to make a report if they know or have reason to believe a child is being neglected or abused or has been neglected or abused within the preceding 3 years. So that within the preceding 3 years is a really important one to remember. And you are obligated to make that report immediately or within 24 hours. And that's an oral report. So that means contacting Child Protection and providing them with the information that's needed to make a child maltreatment report. And then you also need to follow up the oral report with a written report, and you have 72 hours to do that, and that excludes holidays and weekends, which is kind of nice. I know that when you talk to Child Protection, they will say, yes, you have 72 hours, but the quicker you can get it to me, the better. We work really closely with Child Protection at our program, and I know that for providers, they are often willing to take your like a progress note instead of you going online and filling out the whole written report, just because they know that you're seeing patients all day and that it's really hard to fit that into your workflow. So you certainly can do that. Otherwise, I'll kind of show you what other report needs to be made as well. So failure to make a report is actually, something that it's a criminal offense. You can be charged with a misdemeanor. So just kind of noting that. Do I think that that's something that happens often? No. But it's something to remember that this is your legal obligation to do. Okay, so what will I be asked when I make the report? The first thing to just know is that you're always going to be asked a ton of demographic questions. So whenever I make a child abuse report, I make sure that I always have like EPIC right there open in front of me. So it's really important to remember all the information that you're going to give about yourself and then also the specific information about the family. This is a little bit different in this context. But I always want to remind people, like, also know if there are siblings in the home, because I think child protection always, they want to know if there's anybody else's safety who's at risk. And that can sort of impact how quickly they need to respond. And then, like I said, this slide is kind of used for all different forms of child maltreatment. So a lot of this wouldn't really pertain, but specific description of the allegations, whether or not you think the child is in immediate danger, a description of injuries. This one I think is really important, the family's awareness of the report. So our general rule is to be really transparent with families. We believe in our center that having those conversations with families about the need to report actually does more for the relationship with the family than if you don't say anything and you just go and make the report. That being said, if you have concerns about your safety or the safety of somebody else at home, we certainly understand why you would not tip them off to the report. But ideally, and I would say 9 times out of 10, we're telling families that we're making a report to child protection. That conversation can be difficult, and I know a lot of times people don't want to have that conversation, but just speaking from experience, I want you to know that 9 times out of 10, it goes really, really well. That families understand the mandatory reporting obligation. They understand that you have the need to make a report. Very rarely do they get angry. They might certainly be upset. And that's the importance, I think, of coming to that conversation with compassion and trying to not be judgmental. But it can be a difficult conversation. A lot of times, this is just sort of funny, not funny, but having those conversations with moms, you'll be surprised because a lot of times they'll be like, oh, I knew you were going to make that report. That has to happen. That happened in my last pregnancy. Or I know I used to work prenatally with moms who used all the time. And a lot of times I heard, I know I'm going to stop at 20 weeks because I know that once I deliver, then I won't test positive anymore, or baby won't test positive and I'll be all good. So there's a lot of savviness too that moms have. And so sometimes our need to report doesn't really come as a surprise to them. And then tribal affiliation is just a question they're always going to ask because that is needed. Those who have tribal affiliation have a separate sort of child protection worker that works with the tribe. So, because you guys mostly have social workers helping you with this, I won't go into complete detail, but just so you know, since there are times you will not be able to have access to a social worker, the first step you're going to take is to contact child protection and make a verbal report. And so what you want to do is you want to contact the county in which the family resides. That's who you make the report to. And this can be kind of confusing, especially when we're talking about like our physical abuse and sexual abuse cases, because for law enforcement, you are contacting the jurisdiction where the incident occurred, but child protection where the family lives. And sometimes those can be two totally separate things. For your guys' purposes, just remember wherever that family resides, that's the child protection jurisdiction that you want to call. So if you look in EPIC and they live in Hennepin County, you're calling Hennepin County Child Protection. There are 2 different ways to access the form that you need to fill out. One is that Fairview, we have our own form that our center has worked on developing that you can get from Forms on Demand. The other thing you can do is each county, not all of the smaller ones, but the bigger ones, will have their own reporting form that you can access online. And most of them you can just populate online and then submit. The Center for Safe and Healthy Children, we actually keep track of all mandatory reports that go out from this hospital and actually all the Fairview clinics. So anytime that a child abuse report is made, we're asking that all the social workers also send a copy of them to us. And we keep track of them for data purposes, and then also for follow-up with child protection as needed. We are in the process of working on getting the mandatory reporting form into EPIC. We're actually really far into the process. We have a meeting next week, and I'm hoping that that's going to be in place in the next, the way things move, it's very slow, but hopefully the next 6 months or so, which will be really nice and I think make the process even smoother. So we created an algorithm for how to make a report to child protection, and this is something that certainly if you guys want, we can make sure everybody gets a copy emailed to them. It just sort of walks you through the process. Especially for people who don't make these reports very often, if you're doing it every few months, a few months later you might totally forget how to do it. So this algorithm is designed to sort of walk you through it. And this is a copy of the Fairview form that is on Forms on Demand. So right now, reporting for child abuse and neglect is not a statewide system. It is for vulnerable adults, but not for children. So that means that it's county-based. So each county has their own form. Our Fairview form provides all of the information that would be needed. So it is definitely acceptable. And then when reports are made to child protection, we ask people to also fill out a PHI form, which is a protected health information form. And this is basically stating that disclosing information from a from a health record without consent. And it gives an explanation of why we're doing that it's going to child protection or it's going to law enforcement, and sort of gives that explanation of why. And this gets to HIMSS and gets put into the chart as well. And that's the PHI disclosure tracking form. So what happens after I make a report? This is always the question that people want to know, and I think everybody sort of has different ideas in their head about what this report to child protection means. And I know a lot of people really, really worry that this is going to have a terrible impact on families. I do think that there are times that the impact can be devastating, and we can talk about that. But I also want to say when it comes to substance use and pregnancy, there is a lot in our system and our community that is designed to actually help moms who are using. So if a report is made and the mom, so let's talk for a minute about Hennepin County. If you make a report and a mom is using during her pregnancy and she's before 34 weeks of gestation, what they're going to do is they're going to make a referral to Project Child. And Project Child is going to contact them and offer support and services to help them maintain their sobriety during their pregnancy so that once they deliver their baby, they then don't have child protection involvement. So again, before 34 weeks, you get this opportunity to have really good services. And we know that pregnancy is a really, really good time to start talking to moms about their substance use because we know how difficult it is to stop using, but a really, really good incentive to stop using is making sure that you have a healthy baby. And so this is a really good opportunity that we have as medical providers to talk to moms about the importance of getting services and getting sober and having a healthy baby. So Project Child will offer chemical health assessments or help them get connected to getting a chemical health assessment, treatment services, education, support, counseling, community referrals, and they also help with basic needs and provide parenting education. Every county in the state of Minnesota has a program similar to this. They just have different degrees of sort of how big and organized the program is. Obviously, the bigger the county, the more organized they are. So Hennepin County has Project Child. Ramsey County has Mothers First. So these programs are voluntary. If mom chooses not to participate, there is no court involvement to force them to participate. And she can make that decision. It's just going to have sort of a different different consequences as she moves along in her pregnancy. So if you make that report and she's after 34 weeks, child protection will likely open as a child welfare case, and then most likely child protection once the baby is born. So they can't open it as a child protection case during a pregnancy because there's not technically a child. And so they just open it as child welfare, and then once baby is born, it becomes a child protection. So once the baby is born, the outcome of child protection is really dependent on mom's history and the substance use. Like I said before, they can now look at the mom's history. So if she was pregnant 3 years ago and it was sort of like the same situation, that might have a greater impact on the involvement of child protection. So outcomes might include ongoing chemical dependency support and resources, mental health parenting services, and then also, the removal of baby from mom's care if necessary. Sometimes and this kind of goes back to the really important point that I want to make, is that having those conversations early on with moms is so important. Because if we don't, then while we think at postpartum we're just making this kind of, minor report for THC use, it can, and I've seen it, become much bigger than that because of the history they have with child protection. And so those conversations, while they seem minor, can sometimes have a huge impact on what happens with their lives once babies are born. Any questions before? So creating a positive reporting experience. Most people think this is an oxymoron. How can it be a positive experience, right? There's nothing really positive about it. But there can be. And I think especially when we're working with families and it has to do with substance use, it's really important to talk to them about how you have the same goal as them. Our goal is really the same. We want you to have a healthy baby. And I would say 9.9 out of 10 moms really want their baby to be healthy. I might even say 10, right? They do. And their use, for whatever reason, is hard for them to control and maintain, but that doesn't mean that they want their baby to suffer. And so we really recommend talking to families about this in a way that joins with them versus you versus us. If it's more of a way of saying, we really care about you, and we care about your baby, and we have the same goal. So let's work together to figure out how we can make this happen. Like I said before, there might be times that it's not ideal to talk to parents about the report, but most of the time, it's definitely better to be transparent. You can talk about your concerns as well as your need to make the report. We encourage people to maintain a positive, non-judgmental attitude. I know a lot of times I've talked with providers and nurses and who have said, how can a mom do this to her baby? Like, I don't understand. How can she do that? And what I really encourage you to remember is that these moms were once the babies that we're talking about. So they too grew up within these same sort of patterns. And so, it's being able to kind of find within ourselves that compassion and understanding for where they are, so we can provide them with the services that they need so that this cycle can hopefully stop with them. So focus on the services that will be available for support and hope that child protection involvement can be prevented. So once again, it's saying, right now you're before 34 weeks, so we're going to make this report, we're going to get Project Child involved, we're going to do what we can to help you stay sober, so that you and I can make sure that child protection stays out of your life once this baby is born, and to talk about it as sort of a joint effort. Emphasize the importance of having a healthy pregnancy and healthy baby, and then of course being available to answer questions and address concerns. Sometimes our social workers will even make those reports with parents if that's something they want, so that they can be available to also answer questions, but also feel like they're somewhat in control of that conversation. So that's always something that's available as well. So having the difficult conversation, whether you make that child maltreatment report or not, it's important to talk to moms about the potential impact her use can have on baby. And if that, to me, that feels like a no-brainer, like, right, we're providers, we should be talking to parents, to moms about that. But I think that we lose that so often because it's such a hard thing to talk about. And again, we want to stay out of those conflict conversations. But if that conversation doesn't take place, then moms might not have the information they really need to make an informed decision that's best for themselves, for their baby, and really for their whole family. So that conversation is something that can really help direct sort of what happens for them throughout the rest of their journey. A reminder that if mom or baby tests positive at the time of delivery, that child protection report will be made. And parents, honestly, moms have a right to know that. They have a right to know that even if I don't report today, at the end of your pregnancy, when you deliver your baby, a report is going to be made if you or baby is positive. I think that's a piece of information that moms deserve to have. If mom has a child protection history, even THC use or alcohol use during pregnancy can lead to larger consequences. Sometimes we make that report and then we learn that, she had 3 other kids and her rights were terminated, and that's going to lead to an automatic hold, and probably the baby's going to be removed. And just all these things to be factoring in and thinking about. And mom may question why she wasn't told about the potential consequences during her prenatal care. I have had that question asked of me numerous times, so I know that is a reality. So a few scripting suggestions. Just being really clear with them that one of my jobs is to make sure that you have a healthy pregnancy and a healthy baby. And then to really reiterate that, we both have the same goal. And I want to work with you to make sure that happens. And again, just to be really clear, if you or baby test positive at the time of delivery, a report's going to be made. I want to work with you to make sure that doesn't happen. To use those kinds of, I want to do this with you to make sure that doesn't happen. Nobody wants child protection in their life. And we know that typically for marijuana use during pregnancy, child protection usually makes like one home visit, honestly, and kind of assesses the environment and talks to mom, and that's usually that. And I've had patients say to me, oh, I know what's going to happen, and it's not that big of a deal. So I get that, but I think it's still really important to say you never know, and you never know what happens when child protection is involved. It's a risk, and let's just see what we can do to avoid taking that risk. And then, of course, letting them know that as a mandated reporter, you're obligated to call child protection. We really encourage people to sort of reflect that we know that can be difficult to hear and really overwhelming. Offer to answer questions. So do you have any questions that I can answer for you? Things like CPS has resources to help you maintain your sobriety during your pregnancy and after. And then this last one I think is nice because it gives them a little bit of control as well. Is there anything that you want me to communicate to child protection when I call to make the report? Sometimes they want us to say specific things about like, I just got out of treatment, or, I've tried this and that, and, just so that they feel like their voice is being heard as well. And this kind of goes back to what we've been talking about, just this real difficult, I think, providers have in terms of worrying that this is going to impact your relationship, and how to have those difficult conversations knowing that this might impact care. Worried that they will stop getting prenatal care altogether, which obviously isn't something that we want to happen, and which is why I think having these conversations, being transparent, using some of these scripting suggestions can be so good. Because if we say things instead like, you were positive for such and such, I have to make a report, and don't really like engage with them and have these conversations, I think that's going to be kind of a turnoff for patients, and they might not come back for care. And then just sort of the overall question of how do we balance these kind of concerns about the patient and provider relationship with our obligation to make these mandated reports to child protection. And that's, I think, just an ongoing conversation that we need to have with each other. And then I always just bring out my trauma suitcase. People familiar with this? So we all work with families, especially as a social worker. I can say that these moms have trauma suitcases. They're carrying around a lot of trauma with them oftentimes, and we need to be really, really cautious of that. We know, like I said, that it's a lot easier for us to feel compassion toward kids who are experiencing trauma, but these moms, these parents were once those kids, and now they're adults with the same trauma. And so when we're making these reports and having these conversations, to just have a really trauma-informed perspective. And I kind of just like this quote, by supporting women throughout this transition to motherhood, our interventions can contribute to their success in recovering from their substance use, working toward creating more positive life circumstances, and becoming a nurturing and resilient parent, which is really what we want. It's really what we want to see. So creating a culture of compassion, we really do share the same goals as parents do, and that's to have a healthy pregnancy and baby. The vast majority of moms make positive changes during their pregnancy. They really do. Like I said before, this is the time to be really working with families because, it's a lot easier to do sort of damage to ourselves based on our trauma history. But when you start bringing your child into it, I think that's a different story. The other thing is that ultimately, after, when it's time for babies to go home, they are typically discharged into the care of moms. We do see holds placed, and we do see kids that are placed into foster care, and that certainly does happen. But we are increasingly seeing more and more positives for THC, and those kids are going home to caregivers. And so it's really important to know that we don't want to take this sort of judgmental approach, but instead we want to make sure that we're really helping moms stay connected to services and support and resources and help them build that attachment to baby, because ultimately at the end of the day, they're typically going home with each other. Because what we want is best for babies, we need to support their moms. And increasing comfort of moms at bedside will lead them to spend more time with their babies, increasing attachment, which is what we want to see. And then a reminder that the language we use can really impact our message. And so having those sort of like bedside conversations about this, we should be really careful about those conversations. It's really easy to become judgmental. It's really easy to question why parents and moms would make this decision. But again, I remind you of the trauma suitcases that are often leading to some of those choices that are being made. And even our nonverbal communication can sometimes be really tough. And so remember, the more compassion that you bring to that discussion, the more likely you are to see a mom engage and want to make changes. When we provide comfort, families are more likely to ask questions, to look for guidance, and to be receptive to teaching. So at the end of the day, I think that's what we really need to focus on. And I have time for questions, if you have any. Yeah. Yeah. Mm-hmm. Mm-hmm. So, what happens with yeah. Yes, I will repeat the question. So the question is, early on in the process, you have a patient positive for THC use. You refer to Project Child with child protection. They maybe continue to use, right? And then who is kind of following that patient as far as child protection goes? Does that kind of sum it up? So what's really interesting is that so Project Child and Mothers First are connected to child protection, but it's not necessarily like a child protection case. So they're actually pretty separate. So for example, like if Project Child is working with a mom, like I said before, it's voluntary. So if that mom totally I don't want anything to do with this, doesn't answer calls, doesn't follow through, they're going to fall off the radar. I don't know how many attempts Project Child makes, but they eventually just stop trying. And then it's going to be our responsibility to make sure that a new report is made to child protection again, if needed. Does that make sense? So then the inpatient social worker at the time of delivery would make a report, and that would sort of jumpstart that again. But if you're having ongoing, providing ongoing prenatal care, I do encourage you in those circumstances to talk with moms about it. Like, so sometimes it's really easy to be like, okay, I covered that, moving on. I only have 10, 20 minutes with this mom and I'm not going to cover that. I really encourage that conversation to be a continuous conversation. One thing we know about use is that it takes a lot of attempts. It's really helpful to feel like you have people who care about you on an ongoing basis. And even though it might feel like you're being nagging, I think that that's an important part of the process to keep asking. Like, did you hear from Project Child? Did you return their call? Where are you at with this? And just a reminder that, and just to really engage those conversations, I think is important. Other questions? Going once, going twice? Yes? Yeah, so just to repeat, the question is, are you guys aware of social work availability in the clinics and postpartum, I guess, but certainly in the clinics to kind of help with some of these issues, or is this kind of new information? Yes? Kinda? Okay. I don't know if that helps. I mean, I think, most clinics and hospital settings can be different from each other and have varying degrees of support from social work, but I think the important thing to remember is that social workers are really wonderful resources to help with these. And while we don't want you to say, oh, there's a social worker here, I don't have to deal with it, they get to, which can be really enticing. Because we like it more to be sort of a team sport. But just know that social workers are available for this. We have a lot of experience in it. And we also really enjoy engaging in conversations with providers about how to have some of these conversations, because we know what works and we've seen it. And so we would want to have that discussion with you to make everybody feel more comfortable with it. Yeah, and I would say, was that like maybe a few years ago where they sort of changed, the social workers changed that they do like a maternal child health service line, so they follow from beginning to discharge from NICU. So it's really nice to have a consistent social worker with each mom, because then you can really build that trust with the family, and I think it's just been really nice and successful, yeah. All right, well, feel free to ask questions at any point. I'll be sticking around. Thanks. Take like a 10-minute break. I know, because I couldn't find anything. I mean, she made it sound like it. I also have.
You have been disconnected from the meeting.